Assalamu alaikum. Hi everyone. Welcome to the podcast Muslims for Health, Leaving No Kenyans Behind. Today we have the episode entitled Augmenting Medical Education with Islamic Bioethics. And I'm really pleased to welcome our guest today, Dr. Fatma Abdallah. Please, a few words.
Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone. My name is Dr. Fatma Abdallah, a senior lecturer from University of Nairobi in the field of hematology, oncology and blood transfusion. I've been with the university for 23 years, teaching at the Kenyatta National and Referral Hospital in Nairobi.
Thank you, Dr. Fatma. So first, let us see. Do you know where the term university came from? It used to mean in the medieval times, it referred to scholars or masters, a group of scholars or masters. But now over time it has evolved from human beings to buildings. So now it refers to the buildings where teaching takes place. So as I said, the talk is about medical education. And for this session, medical education, we mean all the education that is given to people who are pursuing the health profession. And this includes the basic education, the specialist education, as well as the continuous education. So all that is what, when we refer to medical education, that's what we're referring to. So the first question that I'm going to pose to Dr. Fatma is, what's your opinion of Kenya's current medical education vis-a-vis the advancing, rapidly advancing scientific knowledge, as well as the evolving needs of patients in Kenya?
Thank you. That's a very good question. I think the Kenya medical education is quite good, yet there are gaps that are appearing in the education. I think one is the fact that nutrition, for example, has advanced so much, and such good research has been done and published in peer-reviewed journals on the role of complementing nutrition with current medical education. But if you look at the medical education currently and the number of hours given to nutrition, it's extremely deficient. Nutrition is taught as part of community health in one semester, and maybe the nutrition itself and its role in health is restricted maybe to 3 hours, and it's looking at only a few nutrients and the role of those nutrients in health. And yet if you look at scientific journals that publish on nutrition in health, you'll be amazed at how much knowledge has advanced in that field, and we've not yet incorporated it in our curriculum. So that's one. I think the second one that I can quickly point out is counseling.
Okay.
When health professionals are being taught, counseling is not being stressed as part of the multidisciplinary management of patients. Okay, I mean, doctors are given courses in counseling, but doctors, for example, I'm talking about doctors mostly, they don't have enough time to sit with one patient for 1 hour at least and do good counseling and counsel the patient properly. There's a whole long queue of patients waiting to be seen by that same medical and or professional, and you know, patients getting impatient to be seen, to be the next one to be seen, so that the doctors can't spend that time. So so this needs to, and which has been happening slowly, has been handed over to counselors who are trained in counseling. But the doctor doesn't say, okay, we are going to do 1, 2, 3, 4. I will do 1, 2, 3, 4 for you, but number 5, you will also need to go to the next room or the next building, and you must, part of this management includes that you must see the counselor and get some counseling. I feel personally, even in my own personal life, that I would have benefited a lot if doctors used counseling as part and parcel of their management of patients. Yeah, and then I think we totally, more importantly, is that we totally ignore the fact that the majority of us humans believe in a supernatural being, and that doctors really don't heal. Doctors just treat.
True.
Yeah, the supreme healer is really Allah subhanahu wa ta'ala, our creator. And I think to be able to bring to that is all definitely missing. The theology part of it is definitely missing in the training, and so maybe we end up making our doctors, whether medical or dental practitioners, feel that it's all up to them, and it is, you know, they are the ones who are going to do it, and yet that's not really the truth. So I think briefly I would just touch on those as far as the changes and the advancements that have happened in the medical education, and then also maybe doctors are too busy to read other journals. They only read medical journals. They don't read nutritional journals or physiotherapy journals, you know, to see. Maybe they are too busy. Maybe it's also a challenge in Kenya because we have a very high doctor-patient ratio. All this could be, but I think as far as the curriculum and the training is concerned, these I think are the gaps I can point out very quickly now. And then the other thing is that, of course, now patients go to Mr. Google and they will read on Mr. Google and get a lot of information, and so they will ask questions. And maybe in the training we don't emphasize that there are patient rights, and a patient's right is one of the patient's rights is to have information. And sometimes we're too busy. No, I've just told you. The doctor will say, no, I've told you. This is what I've told you, and this is how we're going to do it. You know, don't read things outside the medical. You know, so sometimes we don't handle patients' queries or asking why couldn't we have done it this other way? Why did you decide to do it this way? Why can't? And then and these days, for example, patients do ask their physicians, can I use supplements? And the training, as I've just said, because the training in nutrition is so deficient, doctors feel no, they don't work. You know, you have to use the medicines I've prescribed. This is what I prescribed for you. Just use what I prescribed. You don't need supplements. They don't work. I think that's really part of the the deficiency, the doctor feels deficient because he doesn't know much about nutrition, because maybe the patient will say, oh, I've had this carotenoid complex as a supplement to boost immunity. What do you think? Can I use it? Will it help me? And the doctor has never heard of it, doesn't know how it works, hasn't read a paper about it. And yet patients are reading and they are being exposed out there to some of these wellness companies that give them this information. So I think there also then the doctor is not able to manage the patient when say, no, don't use it, just use what I've given you and that's it, And yet as I've said, the science of nutrition as well as other alternative medicine has really advanced so much that sometimes we do try and give patients a medicine, they come back, oh, that didn't work, can you give me something else? And they keep coming back, and we are not helping the patient. And that, I think, physicians need to be open to say, okay, let me now send you to a physician on alternative medicine or nutrition, and you go try it. Maybe that will work for you. But we don't. And then but a part of this may also be the I don't know what word to use without stepping on people's toes, but maybe the pharmacological companies also feel threatened if a patient is going to use alternative medicine, use supplements, and yet they really don't need to, because it's in the advancing science knowledge, it clearly shows this is the role of medicine, modern pharmacological drugs and medicine, and it's a different role that the nutrition and supplements play. And yet, if they could be combined, we would be able maybe to manage our patients more satisfactorily. So I think that's what I can say about it, in my opinion. As you've asked, in my opinion.
Yeah, thank you. I mean, from your response, I mean, there are many things that have emerged or you've touched on, One of them is that, okay, we've inherited from the colonialists our curriculum,
Absolutely.
Right? And which is now more pharmaceutically based, so profit. I think that's what was driven, and that previously we did have, if we look at Islamic medicine, it is so broad, because Islamic medicine covers the conventional medicine that they have really contributed to what we call now modern medicine. But we do have the nutrition supplements, we have herbal medicine, we have cupping, we have other, Quran recitation and all that. It's so
prayers.
broad. And prayers and all that. So, I mean, now what we are seeing also, the patient's needs are evolving.
Absolutely.
It's not just a pathophysiological issue or a biological basis that is contributing to their disease.
Absolutely.
Right? So, but the training in the medical school that we get, we spend 3 whole years doing basic sciences.
Yes.
Right? So, I don't know, now in our time we did 2 years of clinical. So, which, I don't know, we didn't have enough exposure to everything. We just did obstetrics, whatever, pediatrics, medicine, surgery, psychiatry a bit, right? So I don't know now if it's evolved to be more years clinical, so that you have more exposure to patients, patient care than what we had.
Yes, there is a bit more clinical exposure in the preclinical years. They're being called tutorials. So that even while they are doing the basic medicine, first of all, the total time spent has been increased from 5 years to 6 years.
Yes.
And in that, a lot of these tutorials have been added in the
Okay. So to increase
in the preclinical years to
patient contact
to begin to expose
okay.
patients students to patients in a limited way, but in
Okay.
at least at an earlier stage instead of later. That's true. That at least has happened, and that's some good improvement.
Okay.
That has happened.
So
yes.
then you also talked about now the alternative medicine in Kenya. What is the Ministry of Health's position with regards to these alternative or complementary therapies, and is it doctors and the people who've already gone through their certified health professionals? Is there a mechanism that they can now expand their training to go into complementary therapies, or is it now we need another group of people who missed out on medical school? They're the ones who are allowed to go there.
Actually, in Kenya right now, there is no institution that is training on alternative medicine.
Wow. Okay.
As far as I know. I heard though that JKUAT, the Jomo Kenyatta University, was planning, but they haven't yet started. They were actually going to offer certificate diplomas, degrees in traditional medicine, alternative medicine, complementary medicine. Yes. So right now, if anybody wants to get trained on that, they have to go abroad. Yeah.
Which is very sad.
Yes, that's true. But the ministry at least does allow them to practice, because the Kenya Medical Practitioners and Dentists Council has been given the mandate to license them, as long as they can produce certificates from reputable institutions. They'll be given a license to practice. But and this is now tells you the attitude of our Minister of Health, that they won't be able to practice in a hospital side by side our contemporary doctors, practitioners. They really have to open their own clinics.
There's that limitation.
They have to. They cannot walk into the hospital and ask and demand to be employed as part of the workforce in a hospital to offer this.
So even if it's a private facility, somebody is
now that. Okay, so I'm discussing. Sorry, I meant the government-run medical
that
facilities.
Is understandable.
In the private one, then that would entirely depend on the CEO or the or the manager of that institution, if he believes in it and thinks that there is a role of alternative medicine and that he can offer jobs to such people within his institution to offer care to his patients. Then it becomes now an individual or an organizational, if for example it's the faith-based organization that are running those facilities.
So that's acceptable.
Yes, because they'll be licensed by the Kenya Medical Practitioners and Dentists Council. Yes, once they've proved and shown their certificates and their transcripts. So that can happen.
I mean, because studies have shown that doctors have, doctors, it's known that they also go to these providers of alternative or complementary medicine. I know all of us have used like the black seed, right? Many of us at the coast use that. I remember during Corona we had the koto that people found it was very effective for COVID symptoms. So, I mean, that's the gap that we need to see how to bridge.
Absolutely.
Because we are looking at the patient's needs. Patients are fearful of the toxic effects of some pharmaceutical medications, right?
That's true. That's very true. And we even the health professionals themselves know that even a simple drug as paracetamol has side effects. And some of them can be quite serious. So they are aware of it, but they don't have the knowledge of what alternative medicine can I also combine with this
Right.
maybe to reduce toxicity or reduce the effects of the medicines and the doses of, or instead of writing 6-7 drugs to give to one patient, maybe he can write 2, and then the others will be from herbals, alternative medicine, or supplements.
Exactly.
Yeah. So there is that gap, and it won't be a simple issue to handle. You can imagine, because the pharmaceuticals will fight it.
True.
Yes, they have an interest in that happening.
True.
As I've just said, instead of prescribing 6 drugs, you prescribe only 2, and the other 2 are supplements or herbal alternatives. You see?
Yeah.
Yeah. So there are issues there that will require some major
thinking, going back to the drawing board.
Yeah, absolutely.
Yeah. So thank you. I think here we have covered about what are the gaps between what the patients need and what is taught, right?
Yes.
And also we've looked at the alternatives that are available, and maybe the health workers or health professionals need to consider, right? Yeah. So from this, what else would you say we need to emphasize before we move on to the next phase of questions?
Okay, I think also what's important is to look at how is the medical or health professional curriculum deficient. I think that we've touched on. But how do you monitor so that the quality of the health care being provided to Kenyans is up to standard?
Yes.
And I think that at least the government has thought about it. For example, the Kenya Medical Practitioner Dentist Council, they provide all the universities with a standard basic curriculum for teaching of medical and dental professionals. And so has also the Nursing Council been given that task for the nursings and clinical officers and the other cadres. So I think if we continue the discussion on the evolving patient care and patient demands, of course patients demand quality, because they know they are paying for it.
True.
In this country, I mean, medical care is not free. It's not free. There was a time it was free in Kenyatta Hospital for the under 5s, and that was really good.
Not anymore?
No, not anymore. That one didn't last long. So as far as quality, I think the Ministry of Health has played its role in setting up regulatory bodies, first of all, like the Kenya Medical Practitioner Dentist Council, the Nursing Council, Clinical Officers Council, and so on and so forth. And these councils' role is to regulate the education. So one thing they have first made sure all these regulatory bodies have is a standard curriculum, because every other day a new university decides, I want to start teaching nursing, I want to start teaching medical students. So those institutions, first of all, have to be inspected by these regulatory bodies, so that they have the required the requirements that are needed for whichever particular education is being done. For example, do they have enough laboratories? Do they have enough teaching staff? And libraries and things like that. So first they have to be inspected and be given a license and be allowed now to start, so that the Kenyan who walks in there isn't being shortchanged. Paying for education, health education is not cheap. in this country, and I guess all over the world. So that's one thing. So they are given the standard curriculum, and then they are given the standard curriculum, be told, and you must follow this, because this is the basic minimum.
True.
Each university is given the freedom to add on and expand in certain areas, but the basic minimum, they have to follow that. So that's one. So that's two rather. Then three, when these health professionals have finished their training and now want to start practicing, these regulatory bodies have been given the authority to provide licenses, but only after they have given a standard exam to those particular professionals. In the whole country. Everybody sits one standard exam, and you either pass or you don't pass, and if you don't pass, of course, you can repeat, so that at least we feel our the health professionals are coming out at the same level, and at a desired level of quality. And then after that, there are still requirements that these regulatory bodies give, because that license is only an annual license.
Right.
And every year before you renew, there are conditions in that you must have attended a certain number of continuing medical education sessions, so that you are keeping abreast of the medical knowledge, and you are keeping yourself informed, so that the care you give the patient is of a reasonable standard and quality. So I think there, at least the ministry has tried, Ministry of Health and our government has tried.
But I was wondering, like, when you say they define the curriculum and what is needed, whom do they consult? Does the community have a say, like, this is what is missing that you need to add? Or is it just an internal decision?
No, for these regulatory bodies to come up with those curriculums, there are certain steps that they've been given that they need to go through. First of all, to get the technical input from the technical people, whether it's the nurses, the dentists, or the pharmacists. And then to have it reviewed by experts, and then there's another step where public participation is included, and then finally for it to be launched. You see, for example, if it's a curriculum for the medicine, for the doctors, it doesn't mean only the doctors will be invited finally. Even the nurses, all the other health professionals that contribute to the patient care are also invited to give their input. So there are rigorous steps.
That's very good. And that's encouraging. I'm glad to hear that.
Yes.
Thank you very much for that. Now we shall shift gear. We're going to now focus more on the cadre, or the distribution of to what level this medical education is capturing people from all communities, right? Because it's crucial that every community has an opportunity to get its own, children from its own who are able to have an equal opportunity and access to medical education, right? Like in the US in 1910, they had Abraham Flexner. He reviewed the whole medical training institution, and what he said was, like, the Negro must be treated by the Negro, right? Because at that time, they were very racist, and they said that a black Negro is the best doctor to treat his own black Negro, and it's important to get the black Negro to treat well, so that the infection does not spread to the white neighbor. Very racist. But when we take the context of that, is we Muslims, right, then is it that our community would prefer to also have its own people to be trained and as doctors, but we know that our Muslims are distributed all over the country. And then when we look at now the health professionals, once they qualify, what's the distribution? Are they really now going back are they equitably distributed to those people who are most in need, or are they all just in urban centers? What can you say about that?
Okay, first of all, I think you've touched on something that struck me. For example, when I was a medical student, we were only 2 Muslims in a class of 100 students.
Wow.
And I think maybe in your class, maybe you are a few more.
Yes.
But you see, that was less than 10%.
Yes.
Isn't it?
Definitely.
But as I finished my specialization and joined the university to start teaching, I then began to notice that the number of Muslim students coming in were gradually increasing, which made me very happy. And I used to tell my students, I'm so happy to see you. A good number of you in the class.
Right.
And I would tell them, in my class, I was the only Muslim girl, and there was only one other Muslim boy.
Wow.
See, at least it was gender sensitive, but just being two of us, you see. So that has improved remarkably. And what was more striking to me is that more of the girls are getting into the medical profession than before, and I think this if you go back, it reflects mostly on the education system.
True.
That maybe for example, I was being told that during the colonial times, the Muslims did not send their children to school because they were afraid, because those schools were being run by missionaries, and they were afraid that when they got to that school, they'll be converted to become non-Muslims. So they didn't go to school, they would go to their own madrasas. And it was only very late in the colonial times, near independence, that they then fought and asked for an Arab girls' school and an Arab boys' school. It wasn't called Islamic, but that's what it was called. That's what the British wanted to call it, for their own good reasons.
Right.
Why call it Arab when it was all the Muslims were going in there from different ethnic groups?
Sure.
But at least now that starts. So when that opened up, then now the Muslim community started saying, okay, now we can send our children to school.
Okay.
At least it's not being run by Christian missionaries. But that I think is only from the coast province. In other the coastal region, in other regions of Kenya, unfortunately, some Muslims did get misled by these people running the missionary schools that come, bring your child, we'll give them free education. But unfortunately, at the end of that free education, that child comes home a non-Muslim. So that happened, and of course that made some other communities very, very wary of it, and they completely withdrew back and said, in that case, we are not sending our children to these schools. So it did happen, but so that's one. Yes, the percentage of Muslims in universities doing health professionals has increased, and therefore, yes, we are getting more and more health professionals who are Muslims, and they are going into different fields of the health field, nursing, dentistry, physiotherapy, laboratory medicine. They are going into it, and then when you come back to the doctors, then they are also now specializing. They are seeing the need to specialize. So I would say a good percentage of them. It's not very common now to see somebody remaining a general practitioner or a medical officer for their lifetime. They are specializing, though of course it's challenging. They're challenging, but that's, I think, a discussion for another day. There are many challenges that they are facing, and hence some of them even get delayed into going into specialization, either because they have to wait, there's a queue system, or the number of course it is true that the number of available slots are fewer than the people who apply. For example, one of the popular one is obstetrics and gynecology. 200 applicants will apply for it, University of Nairobi,
For how many slots?
for only 20 slots.
Wow.
You see?
Okay.
So it's very competitive, and of course some give up and go and try in another direction, in another specialty. But for those who really want to do it, they keep redoing and reapplying and sitting the exam, so it does delay. Yes, they but some of them think out of the box and decide, I can go out of the country and do it and then come back.
True.
Yeah. So yes, the popular ones are obstetrics, surgery, especially orthopedic surgery,
Pediatrics.
Yes, pediatrics, especially mostly for the female health professionals.
Sure.
Pediatrics, and the ones that are not so popular and have the least number of Muslims would be pathology, radiology.
Really?
Yeah, pathology, radiology,
Okay.
psychiatry.
That one has few.
It's only now I think that I'm seeing a lot of Muslims going into it,
True.
but initially nobody
True.
wanted to go into
Yeah, because
psychiatry.
for the longest time at the coast, we just had one psychiatrist, serving from Malindi, Lamu, Mombasa, Taveta.
And he wasn't
just one psychiatrist.
And he wasn't a Muslim.
And he wasn't Muslim.
Exactly.
Okay.
Exactly. So that's what I mean. So there are preferences that the Muslims health professionals are choosing.
But the thing is, after they've graduated,
Yes.
are they now being dispersed to the rural and
Yes,
urban?
that's part of the question I was coming to.
Okay.
Yeah. Unfortunately, most health professionals need or want to work in health facilities, and the distribution of health facilities in the country is definitely concentrated in urban areas.
True.
We have the people living in urban areas, especially the big cities, have a very wide choice
True.
of which health facility to go to. But when you go into the rural areas, then that choice isn't there. Not only isn't the choice there, even the accessibility and both availability and accessibility are limited. And so you find that when somebody requires specialist care and they are seen in the rural facility, by the time somebody they'll be seen by the lower cadastre, by the time they are being seen by a specialist, it has taken several months. And of course it means they need to travel, and therefore there are financial issues to be considered. Because when they finally would arrive, for example, when they are being referred to Kenyatta National Hospital, and we see the referral, we ask them, where were you since you were given this? I was waiting for my husband or my father to get money so that I can travel.
Yeah.
So they do take time, and therefore we end up with late diagnosis. And in some of those chronic conditions, late diagnosis means poor outcomes or guarded outcomes. So medical or the health though the ethics in medicine says justice is one of the ethics, and that there should be equitable distribution of these facilities and all the cadre of staff that go with them, it doesn't really happen. For example, some of the remote areas, let me call them remote, for example, a place like Marsabit, where now they were trying to get specialists in Marsabit town. They really had to offer very, very attractive packages.
Wow. Like what?
For example, that you will work for 6 weeks and then you'll get 2 weeks off, because what happens, most of these health professionals leave their families in the big cities, and so that they can get 2 weeks off to go and be with their families, and very. I was looking at one of the adverts and I was saying, wow, they really have to think out of the box and to be able to attract these specialists to these remote counties or remote regions, so that the people in those counties can also get this specialist care, so that it can be available and accessible and also affordable to them. So the counties have had to rethink. When they were given the health portfolio, they realized those counties that were out of reach needed to really come up with good ideas to attract specialists.
And I think that maybe problem is now more difficult to address, because when you look at in the medieval times, the way they would try to make sure there's equitable coverage is the doctors may be working in the towns and big places. Every now and then they're deployed to the rural to work there. And even I think when we go to Somalia, we see like that kind of thing. But here in Kenya, every county should take care of itself. But I wonder if they tried that model, saying you work in the city, but every year, 2 weeks, maybe you need to go to the rural. Maybe we'd have better coverage. I don't know.
Maybe that or even maybe if they were to provide mobile clinics of some of these specialists, that a specialist will come once a month to these rural areas as a mobile clinic and see patients, so that the patients being seen in those areas be told, okay, next month, this date, the specialist is coming.
Right.
It's not the patient to move and to go to the nearest urban center to look for the specialist, but the other way around. Yeah.
If they can be mandated that it's part of their work, they need to, every doctor should go to the rural. Maybe, I don't know. It's just a thought.
Community.
Because we do like camps, but a camp is you just go for a few hours.
But
it's not sufficient.
No, it's not.
Because at camps you'll go, you'll identify a problem, and then
the follow-up.
The follow-up. They can't come and you're not going. So to me, actually, you're just creating problems.
Yeah, I think you are right that in the medieval Islamic medical care, they had, at that time even they had regular mobile clinics.
Okay.
That concept was actually practiced from the 7th and 9th century.
Exactly.
It was being practiced.
Exactly.
Yeah. So maybe yes. Maybe it should be put as part of the job descriptions, that when you're being employed, yes, you will work in this facility 90% of the time, but one Saturday a month, you will go and provide service to the Mwananchi in the rural area. Yes. I think that's a good idea. That's a way of modifying and using the Islamic medieval practice and incorporating it into the current one and improving on it, making it that better.
So I think we can stop here.